This is the review of COPD guidelines by Meredith Dunsweiler and Jennifer. There are many risk factors for COPD, the largest being tobacco smoke. There's also environmental exposures such as air pollution and occupational exposures. Genetic factors such as alpha 1 antitrypsin deficiency put you at greater risk also for COPD. It's also found to be in older adults and more so in females than in males. Socioeconomic status can play a role because the environment that you're exposed to. And then finally, any chronic lung conditions such as asthma or chronic bronchitis. A diagnosis for COPD can be based upon symptoms and a post bronchodilator test. Symptoms would include shortness of breath, a chronic cough or sputum production, and or exposure to risk factors. The post bronchodilator test needs to be an FEV1 over FVC ratio of less than 70%, which would confirm persistent airflow limitation. There are many lifestyle modifications for COPD patients to consider, the largest being to quit smoking and prevent the further damage to their lungs that tobacco smoke causes. Secondly, thinking about environmental protection, the cleanliness of their environments, and using personal protective equipment in their workplaces to prevent inhalation of toxic fumes. Then, physical activity and nutrition also play an important role in lung health. And then vaccination infection prevention can play a large role in preventing infection. There are three main vaccinations that we need to consider for stable COPD patients. The first is that they get a yearly influenza vaccine. This reduces incidence of serious illness and death related to influenza. Secondly, we're going to talk about the pneumonia vaccinations. So the PPSV23 can be used in adults less than 65 years old with FEV1 of less than 40% and comorbidities to reduce the incidence of CAP. It can also be given once at the age of 65, and then within a year you want to give or a year later you want to give the PCV13, and it can be given in once in a lifetime for greater than 65 years old to reduce the incidence of bacteremia and serious invasive pneumococcal disease. These are important conversations to have with our patients with COPD to reduce the incidence of. We classify airflow limitation through spirometry FEV1 assessment. So you want to assess patient spirometry after you've administered at least one short-acting beta agonist. And over here on the right side, you'll see the different classifications based on their FEV1 percent. CAT is the assessment tool recommended that assesses their symptoms, and it is the most comprehensive. Other assessment tools focus mostly on shortness of breath. However, as we know, COPD patients experience more than dyspnea. Now we're going to talk about the ABCD assessment tool. So, kind of combining the two assessment tools that we've previously talked about to determine treatment for our patients. So, you can look and determine their GOLD 1 through 4 stage based on their post bronchodilator FEV1 over FVC ratio. And then we're going to look at the table. So, we want to look at their exacerbation history compared to their symptoms with the CAT. So, you classify them based on if they've had greater than equal to one hospitalization due to COPD or no hospitalizations due to COPD. And then you're going to look at whether their CAT score is greater than or less than 10. And you're going to match the boxes across based on those two classifications. And again, this is looking to this table, as you can see, shows based on where you fell in the ABCD assessment tool what the initial pharmacological treatment would be for those phases. So, like if you're in group A, you're just going to be on a bronchodilator, so like a SABA. And then group B, you can choose between a LABA or a LAMA. And then you're going to be on a LAMA in group C, and then a combination of multiples in group D. So you can see as they progress, you're going to be adding additional pharmacological treatment. And this table is used to help kind of guide. This is the exacerbation algorithm. So you can use this to help give you some pharmacological recommendations when your patient's exhibiting an exacerbation. So we have dyspnea and other exacerbations listed here. And then you can kind of follow the chart down based on their presentation and their baseline medication as to what you would progress to. And then you see that there are green arrows, and that signifies what you should de escalate their treatment to as they recover back to their baseline. And again, this is used during exacerbations and kind of an algorithm to help you intensify their treatment and then how to de escalate back to baseline.
So, our patient today is Mr. M. He's a 62-year-old male being seen here for a return visit for a 3-month follow up for existing chronic medical problems. Pertinent past medical history on him is that he has severe COPD. His last FEV1 was less than 39% predicted post bronchodilator, and that puts him in the severe category. He also has an elevated left hemidiaphragm and chronic respiratory failure. He is about to begin pulmonary rehab, which he's looking forward to. His chest x ray shows stabilization of his left diaphragm with no acute infiltrates. He has no infectious symptoms, no fever, or productive cough. He was actually just treated with Augmentin recently for an upper respiratory infection, but that has since resolved. He's compliant with his supplemental oxygen. He is on 3 liters with exertion. So when he comes to his appointments, he's using his oxygen. He's on 3 liters. And then when he's at home and he's resting, he's on room air. He is a previous smoker. And he does have some epigastric pain and belching that have resolved from pantoprazole BID. No nausea today. He remains on Stialto daily up until today. This is a LAMA and a LABA, which is appropriate for the stage of COPD that he has. He uses his rescue inhaler twice daily. And he has shown in the past a great benefit from oral prednisone, but it makes him very irritable and he doesn't like to take it usually. So, a history of Mr. M's present illness is he's here for further eval of his severe COPD. As discussed, he does remain adherent to his supplemental oxygen. He's been paying a significant amount of money out of pocket for this Stialto inhaler, as he's failed a Noro in the past, and I'll get to the reasons why that didn't work for him in a bit. He wanted to see if there's an alternative maintenance therapy. Main reason he's here today, because he's spending about $400 a month on this inhaler. He does not qualify for patient assistance, and he's unable to work right now due to his condition and oxygen requirements. He does have a history of CAD, and he follows with cardiology for that. As I just said, he does have a known elevated hemidiaphragm, which was exacerbated by increased gastric distension. aggressive GI regimen, but still has some intermittent abdominal reflux and discomfort. He's had no recent exacerbations requiring steroids and no overt dysphagia. Reviewing of his symptoms for today, pretty much benign for the most part. You can see that he does have shortness of breath, and he does have dyspnea. No abdominal pain, no nausea, no vomiting. So mostly just the dyspnea, um, exertional, especially for him, and then the shortness of breath, which is a chronic problem that he deals with regularly. Um, as you can see, the rest of everything. Continuing on to his vital signs for today, you can see his BMI is 19.94. He weighs 139 pounds and he's 5 foot 10 inches. So this is a little lower weight for him. He has lost some weight recently, over time actually. His respirations are 18 today. Blood pressure is well controlled at 126/78. Heart rate is 75, and his oxygen saturations are 98% on 3 liters nasal cannula. And he's had no recent falls. And then you can see his vaccines are up to date. He had his flu shot in 2019, his PPSV, both pneumonia vaccines are up to date, one in 2014 and one in 2012. So he's current with that. Okay, just going over his current meds. Mr. M is taking albuterol. That's his rescue inhaler. He can have that every 4 hours. Currently, he's doing about twice a day on that, and that's kind of where he's lived over the past 3 months. He's on a daily aspirin, a statin, duloxetine twice a day, losartan, metoprolol, a multivitamin, pantoprazole, and this Dialto, which is the LABA plus LAMA, and that's the one he's been paying such a high price for, um, because he is Medicare. You have to hit your deductible before they will pay, and he doesn't have any secondary prescription coverage. So he's been paying over $400 for that, and it has worked really, really well for him. He did fail a Noro, which is also a LABA and a LAMA. It is a dry powder, and with some patients, the dry powder can cause an increased cough. And this is what happened with him, and this is why he failed the Anoro. So we'll talk about what we put him on in the plan part. Assessment wise today, things that we're addressing are obviously his COPD, his chronic respiratory failure, elevated hemidiaphragm, esophageal reflux, and dyspnea. Other problems that he has that I didn't list on here. He has a very, very long list of active problems. He has had a previous cabbage. Obviously, he has chronic shortness of breath. He's got sinusitis chronically, also bronchitis that keeps coming back and forth. He has some depression. We'll talk about that. He's got diabetes and fatigue, obviously, hypoxia, intermittent claudication, um, and he's had an abnormal stress test in the past, obviously, because he has heart issues, abdominal bloating with cramps, GERD, which that is actually listed here as well. So Mr. M has a very, very long history of COPD and breathing problems, and he's been on oxygen therapy for quite some time now. He's compliant with the treatment plan, but the Stialto has not been financially feasible for him. He failed a noro therapy. We were just talking about that. So today we're going to place him on Duaclear, which is also a LABA and a LAMA. There is a specialty pharmacy that will allow him to have better coverage for this and better maintenance control. The patient has been instructed on the proper use and care of this inhaler. We talked about that and the benefit and the compliance involved. He's demonstrated and verbalized the understanding of this instruction, and he will remain compliant with the supplemental oxygen at 3 liters. And he'll continue to use his nebulizers as needed. He continues not to smoke. Congratulated him on that. And we did discuss today that we feel that he is a candidate for a long-term disability, which is discouraging to him. Obviously, um, he has some depression related to that, and was working full time, and since has had some health problems. Um, but with this new inhaler, it's so new. Same class as the other. But we were able to find a specialty pharmacy so we could get a flat fee of $50 per month, which is much more affordable for Mr. M, and it's going to allow him to be much more compliant with his therapy, and it's not a dry powder. So we feel like this will be very comparable to what he was on before at a much lower cost. So that was really cool. Lastly, are a few other things that we are concerned about going forward and the things that we're going to manage and follow up. He is having a little bit more depression due to his respiratory status and the decline that he's progressing more toward end stage COPD. He doesn't have any suicidal ideation or homicidal ideation today. We've discussed this and possibly, referral to therapist. So we're going to keep an eye out on that. He feels okay for today and wants to just talk about that and follow up. And another thing to consider is that he may benefit from a further GI workup due to his gastric distension and persistent reflux symptoms. Right now, it's pretty controlled, but he is still having some intermittent breakthrough reflux. So we're going to reevaluate this in September and also do a 6-minute walk test at that time, and then sooner if necessary. But right now, we're going to kind of just manage this new med and see if he has the same results from the Cialto. It should be very comparable, being that it's the same 2 classes of medication. But we're going to be kind of looking into that as well. But it was a great visit, and I think we really, really helped him, and we helped him find something that was more affordable and a newer drug, and so it was a really good COPD patient.